good afternoon to everybody. Thank you all for coming. It's a bit of an inconvenient time. We'll try to make it worth it. So, my name is Alejandro Filloy, and it's my honor to moderate this symposium, which once again Lumiber brings you to bring you the latest development in the use of laser for the treatment of retinal disease. For this year, we have changed a little bit the usual structure of the symposium. It will be as you may have seen already, a controversy symposium about 2 specific topics instead of the usual 3 or 4 speeches. So, for that, we have the immense luck of having this panel of experts that will share their experience with us about the following topics. So, first part will be about floaters, specifically about their management. Basically, should we do something about them using the advanced, the latest methods we have, or can we just observe them since they are mostly harmless? Professor Giuseppe Querques and Paulo Eduardo Stanga will discuss about it. After that, it will be followed by a very short recap on the generalities of and indications of subthreshold laser, and then we will have Dr. Marco Lupidi and Kenneth Fong discuss about a very specific topic regarding the subthreshold laser treatment, which is how do we calculate the power we employ in our patients? Should we calibrate, titrate it individually, or can we just use a general parameter the same for everyone? At the end of the session, there will be time for questions. All right, then we'll start. I think, Giuseppe, it's your turn first to defend why should we observe floaters rather than doing something with them.
Thanks for asking me to debate on support of observation for vitreous floaters and opacities. This is definitely an easy win in this debate for me. And as you know, vitreous floaters is something extremely prevalent in, especially in the aging population, in healthy subjects, and almost 2/3 of healthy population is affected by vitreous floaters. It's more prevalent in subjects with high myopia, and this may be often associated with the posterior vitreous detachment, and this is good to know to check for possible retinal tear and retinal detachment. So it's so prevalent that, as you can imagine, there's definitely no reason to treat patients with vitreous floaters. And I will show you a couple of cases in support of this statement. This is the case of a young lady that is otherwise healthy, but a myopic subject. This was the clinical picture when the patient started complaining of floaters. As you can see, there's a posterior vitreous detachment with a beautiful visualization of the ring. And so we decided to wait, and this was the results after 4 months of watching, simple watching, and symptoms were dramatically reducing in this subject. And as you can see from this picture, also the size and the density of the opacity was dramatically reduced, along with a gravitation of this opacity. That was the reason why the patient was no more complaining of symptoms. This is a second case. This is a different patient because it's a patient, is an aged patient affected by neovascular MD, and this patient presented, despite a certain number of anti-VEGF injections, still with a vitreous attached, as you can see from this OCT scan. But at a certain point, the patient started complaining of a new onset of floaters. And looking at the OCT, you can see that the vitreous detached is no more attached there. And this was the clinical picture at the time of complaining of vitreous floaters. So also in this case, we decided to simply watching the patient, no treatment, and this was the clinical picture only a few weeks later without any treatment. As you can see, there was a dramatic reduction of floaters and vitreous opacities, and even though the posterior vitreous detachment was still there. And the patient was definitely happy with this reduction of symptoms. So there are different strategies for vitreous floaters and opacities: observation, laser vitreolysis, and pars-plana vitrectomy. Unfortunately, all the treatments may be affected by important adverse events, and so clinical trials are scarce. This is the only one that was published so far, and you can see there is a very little number of patients included. If you consider that this is a laser versus sham, so it's randomized, and despite this little number, there were 3 cases of retinal tears after laser treatment. And there's another trial that is ongoing. On top of this was the very first large number report by the ICRS. This was a survey among the retinal specialists in the US, and this large number of patients treated with laser, indeed, many of them presented with important side effects, from cataract to IOP increase, retinal detachment, retinal tears, but even to, in some cases, increase in the symptomatic floaters. So you do a laser for reduced floaters, and there's an increase of the floaters. This is the other approach, pars-plana vitrectomy. Also in this case, this is a large series. As you can see from this slide, there are important potential adverse events, including recurrence of floaters, retinal detachment, retinal tears, and cataract surgery needed, vitreous hemorrhage, and around 20% of patients in this series needed reintervention after pars-plana vitrectomy. And we should not forget the risk of endophthalmitis. In this series, 2 out of 28 cases in the end, because of got endophthalmitis, and in the end they reached a very low visual acuity that is much worse than symptoms that were they complaining because of floaters. We also have to remind that apart reduction in size of floaters and even opacities related to PVD, there's a central adaptation, and so over time patients they do not feel no more discomfort with floaters and opacities. And there's also gravitational distribution. So to sum up, considering all the important adverse events and the very good outcome of simple observation, there's no need to treat patients for vitreous floaters and opacities. Thank you very much for the attention.
Thank you, Professor Querques. And now Professor Stanga will give you a piece of his mind regarding this. What you just
I wonder
said.
how we are going to get on a plane to go back to Italy. But, okay, so as you can see there, some people are really troubled by floaters. So we're not talking here about the floaters that appear after an intravitreal injection. We are talking about truly troublesome floaters. So some of my commercial associations. So we know that floaters are a very common complaint, and they are an increasingly common complaint. People can live with floaters, but some people can have mental health problems because of the floaters. Floaters are not just black spots that get in your visual field. Floaters can decrease contrast sensitivity, and that has been very well documented. Floaters are becoming more and more common because of myopia increasing, as you can see on the slide. There are going to be there are already 5 billion people with myopia and 1 billion more with high myopia in 2050. So floaters can severely affect your vision, and as you can see here, you can see the shadow cast by this floater, that very same floater, right on the fovea. And if you are doing certain tasks like driving, that can be severely troublesome. Now, one of the problems that we see, and that was clearly shown in the Optos images shown by Giuseppe, is that floaters are not clearly visible by the examiner, not always visible by the examiner. And ultra-wide field images are the worst way of imaging floaters because of the confocality of the system. You have to remember that an Optos image is designed to bypass opacities. So we do need a good way of examining people, a better way of examining people. Now, there are many reports explaining and looking at the psychological impact of vitreous floaters and opacities. And here are some of them. And the younger the patient, the more troublesome they are from a psychological point of view. So we have come up with a new testing modality to assess vitreous floaters and opacities, the SKVFO test, which we have published, because it can be difficult to correlate the clinical findings on biomicroscopy with symptomatology. So Stuart Harmer showed that floaters do not need to be visible to the examiner for them to be troublesome. And let me show you these two examples. This is ultra-wide field OCT, and you can see this patient here on the right. This patient is asymptomatic, and you can see this other patient here on the left who is symptomatic. This patient has an attached vitreous. You would see those two scans. They look very similar, and it would be very difficult to know which patient is symptomatic. But just bear with me, and we'll get back to that case. Now, in order to understand floaters, it's essential to understand scatter, because floaters do scatter light. Any interface within the vitreous, an interface between gel and fluid, is enough to scatter a light. And we have forward scatter, and we have back scatter. So the patient sees the floater when there is forward scatter, but the examiner only sees the floater when there is back scatter. So that is something important to understand. And not all floaters induce back scatter. So that's the ophthalmologist perspective. Now, when my wife says that I'm ignoring her, I tell her that's because you are not back scattering light. So this is the SKVFO test. I'm not going to go into detail in the sake of time, but in the interest of time, but you know, the publication is out there. And we have objectively assessed the effect of vitreous floaters on contrast sensitivity and how they scatter light and the effects on vision. And this is some of the technology that we have used. We have used an HD analyzer, a light disturbance analyzer, and a sequant, because we've borrowed this from the refractive surgery world, and because we wanted to objectively establish the effect of vitreous floaters on vision. Vitreous floaters affect vision, of course, affect best corrected visual acuity, but intermittently. As soon as the floater comes out of the way, they have 6-6 vision or 20-20 vision, 10-10 vision, however you want to call it. But that doesn't mean that their vision is right. We have to remember that stray light reduces contrast sensitivity. And these are some of the results. Here we've got an index. This is before selective vitrectomy, and after selective vitrectomy, we are getting indexes. I'm not going to go into detail in the interest of time, but you can see that we are objectively assessing the patient before and after surgery. This is the area of light disturbance before and after surgery. You can see an index, you can see the dramatic change in index, and you can see the changes in the area. This is here we are measuring forward scatter, sequant, how much the floater is affecting vision. And you can see that we have a curve, there's normative data, results before and after surgery. Look at this example. Look at those opacities. These are the opacities we are treating, not a patient after an injection of anti-VEGF. Those are definite opacities. And you can see here before and after selective vitrectomy. They are definitely opaque, as you can see. Now, this is what we call selective vitrectomy. We are not doing a full vitrectomy. When Giuseppe is talking to you about the risks of vitrectomy, he's talking to you about full vitrectomy where we induce a posterior vitreous detachment. First of all, before any treatment of vitreous floaters, you need to do a full vitreoretinal examination. A full vitreoretinal examination means doing indirect ophthalmoscopy with scleral indentation. And that has to be done by a vitreoretinal surgeon, not a glaucoma surgeon, not a cataract surgeon, which have been mostly talking about laser treatment. So what we do is we do a less than a core vitrectomy. We are removing just the opacities within the central area. We leave the retrolental vitreous, we leave a cortex of vitreous. It's a minimal approach. Here you can see what I mean by a minimal approach. Before and after selective vitrectomy, and you can see the cortical vitreous still attached to the cortex. There's no doubt that this patient is symptomatic. Look at the floaters bouncing in the vision. This is infrared light. Do you think it's easy to see through that shower of floaters? It's very, very troublesome, and there's no need to be troubled by that. People keep being told you're going to get used to the floaters. These floaters do not disappear. You know, this is vitreopathy. These floaters do not go away after 6 months. We do tell patients when they come with an acute PVD and a vice ring, wait 6 months because most of your floaters will disappear, if not all of them, and it's only after that that we consider treatment. And this is what we do. This is a selective vitrectomy. Look at the size of this floater. These are the type of floaters that we treat. It's completely obscuring the macula. And this is the surgery of this patient. Okay? So it's not that we are, in this patient, we did not induce a PVD. This is not the posterior hyaloid. And I'll show you why I'm saying that. Because this is the before and this is the after selective vitrectomy. Look at these floaters. These floaters, when they move in front of the fovea, they are obscuring not just the fovea, they are obscuring the whole of the macula. So it's impossible for them to see. And you can see that there is a partial PVD, and it is still there, the same as before, after the surgery. So it's a minimally invasive surgery. And these are some of our results in 27 patients. And you can see that we have a significant p-values objectively looking at the effect of vitreous floaters on the quality of vision, not just visual acuity. We also do treat floaters with laser, but we don't use the standard YAG laser. Yes, I have a commercial association. I'm a consultant for Quantel that sponsored this symposium, but this is why we use this laser. As you can see, this is a laser where the laser beam follows the same path as the light beam. So that's why the mirror drops and we can do and we can target the laser and go very deep. Now we've been doing YAG vitreolyzer and surgical treatment for several years. I think we started with YAG vitreolyzer in 2018 or 19. And this is what we presented at the Jules Gonan meeting. This is the laser in my office. And this is, some patients need more than one session. This is what we did achieved in the first session, the second session, and the third session. You can see how much we are destroying the floaters, the vice ring, as time goes by. Now, this is a very, very rewarding treatment. Look at this. I'm gonna be quiet and let you look at that video. This was the very first treatment I did. This looked like a rope, but look at this. It's like a game. There's no reason to have to put up with that large vice ring that's been there for well over 6 months when you can destroy that vice ring. This is one setting. This is an unedited video. Yes, there are risks, of course. Every treatment carries risks. And Giuseppe does intravitreal injections, I'm sure, and they also carry a risk. So here you can see the results, again, with positive p-values, and these are moving towards the green as we increase the numbers. This is an ongoing study. So in conclusion, VFOs, or vitreous floaters and opacities, are one of the most common complaints. We have to remember that VFO causes light scattering. This decreases quality of vision and quality of life. VFO can reduce best-corrected visual acuity. We have seen this, and we've just got a publication that's going through a review process that also will show that, and contrast sensitivity. And we have objectively assessed stray light measurements. So we need to understand better what floaters are, the characteristics, in order for us to be able to advise patients on what the best treatment course is, whether observation, surgery, limited, I don't do full vitrectomies for floaters, or YAG vitriolysis is. And we go back to finish to the case I showed you before. On the left, this patient is asymptomatic, this patient is symptomatic, and if you wonder why, and the reason is because these floaters are, or these interfaces are causing significant forward scatter, as we have shown with sequent technology. So you can see that the results are above the age-matched population. And this is one of many young patients that come to see us complaining of vitreous floaters. You do a slit lamp examination and the vitreous is completely clear. And these patients are on antidepressants. There's no need for patients to be on antidepressants because of vitreous floaters, even if you do not see them on biomicroscopy. Once somebody said to me that normality is the absence of adequate testing or enough testing, and I think this is one of those cases. So do we need to treat floaters or not? I think it is important to be aware that of the current availability and safety of treatment of vitreous, or of treatment options for vitreous floaters. Yes, we do not have to treat everybody, but there are patients who definitely benefit from treatment of vitreous floaters. I don't work alone. This is a part of a team. Thank you very much to all of you for listening.
Thank you, Professor. Now we have a few minutes left for rebuttal. We'll give the chance first to the contendants. Professor Querques, any rebuttals you would like to express to us?
Well, I have a question rather than comments to Paulo. How long do you wait before treating patients with floaters? I mean, I showed a couple of cases that were in only a few weeks dramatically improving spontaneously. Are you waiting how long before starting it, deciding to start with the treatment, especially if we consider the potential risk that may accompany this treatment, as I showed in my presentation?
Thank you, Giuseppe. That's a very good question. Yes, we do. We wait 6 months. It's arbitrary. Why 6? Why not 5? Why not 7? Well, 6 months. When a patient comes with an acute PVD, so started with symptoms of flashes of light and floaters, photopsia and myodysopsia, and we always do indirect ophthalmoscopy with 360-degree scleral indentation at the first visit. Always, every patient. In fact, we do that in every patient that comes through the doors of our clinic. We have an independent clinic, so we don't have some of the difficulties that other state-run systems have. So we have that advantage. But we do that. We never do treatment for vitreous floaters in an acute, hot, when the patient has just had a PVD and is still having photopsia. We don't do that. We tell the patient that we need to do a follow-up because of the possibility of late retinal tears. Now, in absolutely none of the treatment modalities that we've had, we've seen late retinal tears, neither in the YAG vitriolysis study that we are currently doing. We are recruiting 50 patients ourselves. We've invited Jerry Sebag in the US to recruit another 50, and none of us has seen retinal tears because of the YAG vitriolysis. However, we do a very thorough retinal examination before laser. So every patient undergoes indirect ophthalmoscopy with a 360-degree scleral indentation. And if there are holes with fluid, we pre-treat them with laser retinopexy before doing the laser treatment. But retinal lesions from the laser we have not seen.
Do you have a way to, a standardized way to quantify in these 6 months how these floaters are changing, and eventually do you have a soil, a threshold for deciding when it's the right moment to start with the treatment? You showed that the C quant that was really amazing. Is
yes,
that the way?
Thank you very much. That's a very good question. We do. We always try, all our patients, every patient that we operate with selective vitrectomy, and selective vitrectomy takes literally, of being inside the eye, it's 20 minutes, 25 minutes maximum. It's a quick procedure. It's not a full vitrectomy. You have to bear that in mind. Every patient undergoes what we call the SKVFO test, standardized kinetic visual function test, because remember that floaters move and they change shape, they change position. That's why we've developed that test. That's published in the journal. We published it last year in the journal OSLI. So we do before and after, and those are the results that I've shown with the p-values.
I would have one extra question. When you decide to treat, how you decide the technique, I mean, between laser surgery?
That's another excellent question. I think it's essential to offer to discuss with the patient all available treatment options. I say to the patient, look, we can observe your floaters. The floaters are not going to kill you. They are not a disease. You can live with your floaters for the rest of your life. It's a question of whether you want to put up with them or not, how much they are affecting your vision and your quality of life. By the way, we do quality of life questionnaires, as you've seen in the photographs. Sorry. We also discuss in terms of vitrectomy, full vitrectomy versus selective vitrectomy, the differences, and we discuss YAG vitriolysis as well. If a patient comes with centrally located, clearly defined floaters that, and the patient understands that laser treatment is not just one session, that most likely will need between 1 and 3 sessions, I think that's a good candidate for YAG vitriolysis. A patient that comes with peripheral floaters, very mobile vitreous, very syneretic, very liquefied vitreous, that's not the ideal candidate for vitreous floaters. The best candidate is a vice ring, but then you have these cloud-like floaters that are in the center that also respond very well. But with the YAG laser, you cannot reach the peripheral floaters. There are patients that, because we all tend to imagine floaters as opacities in the vitreous from the accumulation or the clustering of collagen fibers. But we have to remember that some patients have vitreous floaters because they've developed vitreoskisis or they've developed a PVD. And the posterior cortical vitreous, and we've got this in our presentations and the paper that we've submitted, when there is a PVD or vitreoskisis, the corrugation in the vitreous cases. That scatters light, and that is enough, as I've shown in that photograph, in that scan, to scatter light, and we've shown that we've objectively assessed that with sequin. And those patients benefit more from a limited vitrectomy, selective vitrectomy than laser.
Excellent, thank you very much. We'll move into the next session. If we can go back to my presentation.
I think we're still friends.
All right, as we were mentioning, the second part of these controversies will be about subthreshold laser for macular disease, specifically about one very specific topic, how we determine the power that we are using in our treatment. Meaning, should we just use universal parameters, the same power for everybody, the same parameters, or should we adjust the power using titration, calibration of it individually? First of all, let's make 2 minutes, I promise, quick recap on the generalities of subthreshold laser. Remember that when referring to it, we speak about laser technologies that after treatment will not produce any clinically visible effect, except clinical result, of course. Any clinical visible effect in the retina as pigmentary, inflammatory, any kind of changes. In fundoscopy, on OCT, on autofluorescence, if you can see it, it was not subthreshold, it was something else. I mean, this excludes, of course, the beneficial results. This is why the laser remains under the threshold, hence the name, of physical damage. And threshold subliminal laser attains so by delivering the laser not as a continuous pulse, but as a series of pulses, short pulses, microsecond each, those allowing between one and the following a series of cooling periods, which will prevent the retina from reaching what we may call a critical temperature. Well, not the retina, the RPE. And all right, why do we want to stimulate under this threshold of physical damage? Well, this is because we know that acting in this way, we stimulate changes in the RPE metabolism. There is an increase in secretion of anti-inflammatory, anti-oxidative, and repair factors by RPE and probably indirectly by the Müller cells. We know this is true in vitro. We know this is true in vivo. So, might say that a laser burn has no intrinsic therapeutic value. We can exclude it from the equation and still get the good results. We are talking here about macular laser, of course. PRP, retinopexy, they work in a different fashion. So when performing subthreshold laser, you are performing a surgical procedure. So it's operator dependent, and standardization makes it safer, more reproducible, and quicker to learn. And that's where protocols come. A few years back, we created the Subthreshold Ophthalmic Laser Society in order to bring a little bit of order in this rather chaotic world that is subthreshold laser. Our first work was hence these parameters, these guidelines, which were results of a consensus between about 20 experts from all over the world, different groups, users of different devices. This is important to underline, which finally resulted in this work coordinated by Dr. Jay Chablani from Pittsburgh. It's freely available at I and PubMed. Well, let's see them a little bit closer. So we agreed on a duty cycle of 5%. This little non-discussion about it is pretty much universalized, and a pulse duration of 200 milliseconds, which, taking into account this duty cycle of 5%, means that the effective laser time is 10 milliseconds, which are spread evenly along these 200 milliseconds. Spot size between 100 and 200 microns. Dense pattern, which means spots right next to each other, no leaving blank spaces, so we recruit as many RP cells as possible to work for us. And finally, power. The final result of consensus was that we should titrate power at 50%. It was not at all a full consensus. Some of those doctors still today work at fixed parameters. That's why maybe it's the most interesting topic to discuss. What do we mean by titration? By titration, we mean that right before treatment itself, we start applying single laser shots in the peripheral healthy macula at increasing power, until we see a very small, very faint reaction. Then we take that power necessary for that faint reaction, reduce it to a 50%, and that's the power we will work over the 6 zones. And finally, should we titrate really? Should not? Dr. Marco Lupidi is going to explain as well. We should not, in fact.
Thank you very much, Alejandro, for the kind introduction, and thank you to Lumibrid for the opportunity of being with you today, and thank you all for remaining with us after a very long day at the meeting. So I will start directly from the answer. Do we still need the titration for our subthreshold laser? Definitely not. These are my disclosures. We all know that the damage that we induce at the level of the retina, and this is documented from a clinical pathological point of view, mostly depends on the pulse duration and the laser power. And this type of damage has also been showed simultaneously on structural OCT, and the structural OCT shows that the very early damage we can observe just after 1 hour after treatment, and these, dependently from the duration of the pulse and from the laser power, may affect the RPE, the outer P and the outer nuclear layer, and also obviously the photoreceptor layers. So, as introduced by Alejandro, we know the destructive action of the thermal laser, which is mostly used to reduce the oxygen consumption, to reduce the vasoproliferative agents, and also to improve potentially the oxygenation of the retina. While at the reverse, the rationale of using a subthreshold laser, which is a laser which produces absolutely no visible changes or damage during or after the photocoagulation, is to produce the heat shock proteins to activate the RPE with an immunomodulative action to trigger the repairing process, or also to normalize the production of certain cytokines. But what do we mean by visible? When we look at our ophthalmoscopical examination, which is the most relevant examination when we perform the titration, so to detect if there is a damage related to our laser spot, we can clearly see that in this case we have no clear evidence of the damage itself. But if we move toward different imaging modalities, they might be much more sensitive in detecting the lesions that we have just performed with our laser. And these are visible both on multicolor imaging, on blue autofluorescence, and obviously at the level of the OCT with this little jump of the retinal pigment epithelium with a subthreshold spot at laser power of 800 milliwatts. So, what we wanted to do initially was to compare different imaging modalities in identifying the laser burn and to investigate the short-term photoreceptors alteration that we can obtain after the subthreshold micropulse laser treatment. For this purpose, we used, and in order to evaluate the damages at the level of the photoreceptors, the spectralis high magnification module that provides an optimized visualization of the retinal photoreceptors mosaic pattern with the high-resolution images that reach 1.47 micron per pixels. So we have a good visualization of the entire photoreceptor mosaic in the assessed area. We start with a monocentric observational study. A patient affected by diabetic macular edema with a central retinal thickness lower than 400 microns were treated with the EURETINA, the 577 laser, with a subthreshold approach, obviously, and all the treated areas were assessed with the high magnification module for a qualitative and quantitative assessment of the photoreceptors, and as well with the structural OCT, with the fundus autofluorescence, with the multicolor scanning laser imaging, and obviously with the fundus biomicroscopy. And 2 different imaging sessions were performed for each imaging modality, both at baseline, so before the treatment, and 1 hour after performing the subthreshold micropulse laser. We enrolled 118 eyes, and obviously we performed both three different treatment approaches. One with the titration mode, the same laser we used with the spot size of 160 microns, the exposure time of 200 milliseconds with a 5% duty cycle, as shown by Alejandro a few minutes ago, but with 4 different power values for the titration, 600, 800, 1000, and 1200 milliwatt. And then, obviously, for this, the approach was for treating the area, a reduced power to the 50% of the threshold power was performed, and then we started to treat the same patient with a fixed treatment regimen with a dye density, fully confluent fashion with the spot size of 160 microns, the same exposure time, 200 milliseconds, 5% duty cycle, with a power, fixed power at 250 milliwatt. This is what we obtained with the titration mode, and obviously there is the titration area. You can clearly see the differences in between the 800, 1000, and 1200 milliwatt, but both on multicolor, both on structural OCT, where we see with the 800 just the change at the level of the photoreceptors and the RP, and also outer nuclear layer. But which is the percentage of detectable spots during the titration mode with different imaging modalities? So if we look at the slit lamp biomicroscopy for the 600, we have almost no visible spots, and they are slightly detectable on multicolor, autofluorescence, and OCT. But when we move toward 800 milliwatts, we can clearly see that just 2 out of 10 lesions were evaluated, were visible on the slit lamp biomicroscopy, but they were detected in 7 out of 10 cases with multicolor autofluorescence. And this percentage also is relevant for the 1000 milliwatt, where just 6 out of 10 lesions were visible on slit lamp biomicroscopy, and then they were completely visible both on multicolor and autofluorescence. So we were obtaining treatment that were definitely much more visible on different imaging modalities than compared with the slit lamp biomicroscopy. And this is what we obtain for the photoreceptor, for a fixed regimen, when we perform an automated AI-based count of the photoreceptors for a baseline and 1 hour after the subthreshold laser. And the same was performed for with the titration mode for the areas treated, obviously reduced by 50% of the power of the titration. And the count is also performed 1 hour after. And for the quantification, we can clearly see in the table that there is no statistically significant difference in terms of photoreceptors count from baseline and 1 hour after the treatment, but this difference comes statistically different in the area treated with the subthreshold approach, but with a previous titration mode. So we strongly recommend, as the Light Society suggests, that titration is substantially discouraged by the light because it increases the likelihood of unintended retinal damage, and fixed laser parameters with the identical setting for every eye show to be reliably safe and effective. And you can clearly see that there were no significant difference in between the 2 different approaches in terms of outcomes for the whole group. So also in this case, we treated with a power of 250 milliwatt, 200 milliseconds for the exposure time with a duty cycle of 5% with a high density pattern of confluent laser foci on the fluid area. So just to conclude, the laser-induced retinal damage should be assessed with a multimodal approach rather than a conventional biomicroscopy. The multicolor and the autofluorescence is the more sensitive imaging modalities to detect the laser in the area treated but preceded with a titration mode. The photoreceptor counts shows no significant change when we use a fixed parameter, so it means that we spare the photoreceptor integrity and also their alignment. And finally, the fixed treatment appears effective and more suitable in reducing the potential risk of iatrogenic damage due to wrong titration. And so, do we still need the titration before performing SMOP? Absolutely not. Thank you very much for the kind attention.
Thank you, Dr. Lupidi. And now, Dr. Kenneth Fong has come all the way from Kuala Lumpur to tell us why we should, in fact, be titrating our patients.
Thank you very much, Alejandro. Good evening. Thank you very much for staying, and thank you for giving me the opportunity to share our experiences with subthreshold laser. I enjoyed Paulo's talk and Giuseppe's talk very much as well. So really, my task in the next 8 minutes is to convince you that titration actually is very important if you are considering subthreshold laser, and I'll explain in my next few slides why. Retinal laser photocoagulation has been around for many, many years. All of us are very familiar using it as a modality for diabetic retinopathy, pan-retinal for laser photocoagulation, and also it has developed immensely in the last 20 years or so, and it's become a very safe modality of treatment, especially for macular diseases. And however, in the era of anti-VEGF and long duration devices, we are using it less and less for macular diseases. But there is really an important role in our increasing cases of diabetic macular edema cases around the world, where I feel that there's a very important role in combining it together with the anti-VEGF treatment. And in specific cases, when we treat cases of central serous choroidal retinopathy, this is often the first-line treatment. We have no time to go into the data about this, but there's very good evidence published around the world that subthreshold laser is highly effective for CSR patients. And as you know, Visudyne and photodynamic therapy is also very limited worldwide. Both Alejandro and Marco have also shown that there's upregulation of the, when you trigger the RPE cell, you get the increase of the heat shock proteins that help normalize the pathogenic retina and the anti-angiogenic and restorative in nature. So there is a reduction of VEGF levels and restoration of Muller cell function, widely shown by many basic science studies, as well as in animal tissue as well. And also, Stella Vujucevic has shown that you can also improve retinal perfusion after performing subthreshold laser in patients with diabetic macular edema. So really, while Marco has shown very elegantly, you can image damage or laser burns by increasing the power or fluence with multimodal imaging. The real aim of subthreshold laser is really not to induce these burns, whether visible or not with autofluorescence, or angiography, or OCT. And you have shown that the safety of subthreshold laser with no detectable damage visible to the RPE photoreceptors. So really, the whole point of threshold laser therapy is to give the minimum amount of treatment that you need, but enough to induce changes to the retinal photoreceptors and RPE to improve macular edema. And there is a therapeutic window that we have to understand. Whether it's visible, it could be damaging, because we don't know the long-term, we know that over time, 10 years, 20 years, these laser scars will enlarge, and especially if we're lasering close to the fovea macula, there's a risk of enlargement of the scotoma over time. So we feel that it's important that you try and give the lowest possible power treatment, but get the best possible effect. So the advantages of no visible tissue, subthreshold laser is to spare the retina from burn-related damage or side effects. You stimulate the RPE to produce the heat shock proteins and immunomodulate the metabolism and improve its function. However, a biggest argument is that a lot of physicians, when they are starting out with this laser therapy, they are unsure whether they've done enough laser therapy because they do not see a burn, and there's a bit of insecurity about whether or not you're going to have any beneficial effect to the patient. But again, we have no time to go into this. There's many publications showing that there is indeed an effect with subthreshold laser without any visible burns. So I think I won't need to go into this. Alejandro has already pointed out, this paper took about 2 years to come. We worked very, very hard. Engaging retinal specialists around the world, all who are subthreshold laser users, but we are agnostic in terms of the machine. So these are laser users using a variety of companies, but we're very experienced laser users. And then we took many rounds of discussion before we came out with a consensus statement that we do indeed encourage titration. And again, the most important thing is you choose a spot outside the fovea at 5% duty cycle, 160 micron spot size, a dense treatment. You choose a power until you see a barely visible burn. And on the EasyRed machine, there's just one button that you press, and it immediately reduces the power by 50%. So that really solves the problem of the fear that you're over under treating the case. But I cannot comment on the other machines that have the subthreshold laser function. So it really allows individuality of treatment. So in the era where we have to individualize the care for our patients, whereby laser energy absorption are multiple and complex. It depends on the degree of pigmentation and RPE, the transparency of media, today or do they not have a cataract, the status of the retina, and by a 50% reduction after you see a barely visible burn, we feel that this method is safe enough to prevent any damage to the retina. So again, there is a paper published by Victor Chong and Jay and myself where we argued against the letter written about the importance. There was a comment about a side effect of hyperplasia of RPE secondary to subthreshold laser, and we argued that that happened because the authors did not perform titration, and hence the complication seen. So we do not have spacing between spots, and we encourage dense treatment. Again, this is another reply to the PLACE study, whereby they found that there was weakness in the subthreshold laser in performing in treatment of CSCR. And again, we argued, number one, they did not titrate, and they did not perform a dense treatment, and they used a much older generation machine when performing that clinical trial. These are my last two slides. Not everyone's the same. We live in a globalized world. I can't comment about Marco's patients in his diabetic EME study, but certainly in my practice, I see a range of patients on a day-to-day basis. And your skin pigmentation also reflects the amount of pigmentation in RPE. And I think without titration, there is a risk I could be over-treating or under-treating some patients. And I think that's the reason why we have to acknowledge that every patient requires a different level of power. That's really the only thing you need to adjust when you're doing subthreshold laser. Again, this is a typical patient who presents to me in clinic with diabetic macular edema, middle-aged patient with nuclear sclerotic cataract. And if I just treated the patient with 200 milliwatts of power at 5% duty cycle, I highly doubt that much of the laser would be able to reach the RPE layer. So in summary, this is the treatment parameters. We've been through this many, many times. I'd like to thank you, and you're welcome to scan the QR code for videos, more discussions. Sure, go ahead. Yeah, but it's all on the QR code on the SOL's website, where we have done more than 4 years worth of webinars and training videos and stuff. And we've been through this. Actually, we had a very similar debate to titrate or not to titrate in India and China, and always very active discussion. And I look forward to the question and answer to follow. Thank you very much.
Thanks.